One of the first jobs I had after graduate school was with the Massachusetts Maternity and Newborn Regionalization Project. The project director was Dr. Ann Pettigrew, a former assistant commissioner of Massachusetts. I was originally hired as a health planner to work with the 6 regional health planning agencies in Massachusetts and with the Perinatal Welfare Committee of the Massachusetts Medical Society. The second year, I was the co-director of the project. The first project I worked on was a consolidation of small obstetric units in the same areas of Massachusetts. The American College of Obstetrics and Gynecology recommended in '73 that the ideal size of an obstetrics unit should be at least 1,500 births per year in an urban, suburban area. Obstetric units in the 500 births per year should be at first asked to consider consolidating an obstetric unit with larger nearby units. The College of Obstetrics and Gynecology believed that smaller units did not have the staffing experience to properly handle unforeseen, complicated cases. I was asked to speak with hospitals in small obstetric units in their boards of directors. There was a lot of objection from several of the hospitals, especially for the loss of jobs. I was asked by Dean Egdahl of the Boston University Medical School to make a presentation to a group of business leaders he had brought to Boston. I was asked many questions by the business leaders about what they could do as trustees of local hospitals. What questions should they be asking? I tried to share these questions with the 6 regional health planning agencies in Massachusetts for them to ask the hospital trustees in the areas that they served. I met with the Perinatal Welfare Committee of the Mass Medical Society every month. Dr. Ryan, chief of obstetrics at Boston Hospital for Women, later Brigham and Women's, told the committee of my publication when I was at Cornell. I met the Massachusetts Commissioner of Public Health, Jonathan Fielding, at one of the meetings. We became friends, and I have future lectures about him and the company he set up after leaving Massachusetts in the Jonathan Fielding School of Public Health at UCLA. I also learned at the meetings of the Perinatal Welfare Committee of a study they did with Dr. David Rutstein. Rutstein became a friend and is the author of an article measuring the quality of medical care in the New England Journal of Medicine in 1976, and this is subject of future lectures. He was the Commissioner of Public Health in New York City and a professor emeritus at Harvard Medical School with an office on the 7th floor of the Countway Library. Dr. Rutstein liked to stir things up. He did a study with the Perinatal Welfare Committee of the Mass Medical Society that found that 37% of infant deaths in Massachusetts were preventable in the late 60s. The Mass Medical Society would not let them publish the research. Dr. Rutstein gave me a copy of the research that I referred to many times. A second major part of the project was a visit to every obstetric unit in Massachusetts by our Perinatal Welfare Review Committee. A board-certified obstetrician, neonatologist, anesthesiologist, and perinatal nurse visited every unit and did a review of their practices. Each unit was given a report of what they did well and what they needed to improve. Each hospital was asked about a new program that was available, the immediate transfer of high-risk babies to one of the 12 neonatal intensive care units in Boston, one in Worcester, one in Springfield. A community hospital could call a neonatal intensive care unit and have a team of neonatologists, anesthesiologists, and neonatal nurse at the community hospital in a van and begin immediate treatment. Hospitals were given the number to call and the procedure to use. Dr. Leo Stern from Toronto, later at Brown University, told us how they monitored hospitals of birth and hospitals of death in Canada. They could identify if too many babies were dying in the hospital of birth, indicating babies were not being transferred. I was asked to put together the database to monitor the percentage of transfers by hospital of birth. The hospitals were told that we would be monitoring how often their low birth weight and other problem babies were being transferred. 2 physicians at the Tufts Medical Center noticed that family doctors who had served in the Boston neighborhoods were passing away or were retiring. Recent medical school graduates were not replacing them. Many of them wanted to be specialists and serve in the suburbs where they had health insurance. They came up with an idea of establishing a neighborhood health center in the late 60s that would be organized and controlled by the neighborhood. They decided to set up the first of these centers at the Columbia Point Housing Project, now the Kennedy Museum in Boston, and on the Mississippi Delta. They would train members of the housing project on how to organize, establish, and run a health center. I will talk about their work in a future lecture. An organization called the Massachusetts League of Community Health Centers was set up by Kathleen Crampton. I met with a group of public health advocates and retirees from neighborhoods that wanted health centers. 3 of their priorities were to get support from the city of Boston to help fund the development of health centers, to get Blue Cross to reimburse health centers for their use, and to have the doctors at the health centers get access to the teaching hospitals' many privileges. One person who attended the Mass League meetings was Lewis Pollock, the Assistant Commissioner of Health for the City of Boston. We became good friends. He was very interested in the potential for the City of Boston's maternal child health project from our project I was working on. I told Lou about a new study we were planning to do on the adequacy of prenatal care. He knew that the City of Boston, with all of its teaching hospitals, that if pregnant women were not receiving early and adequate prenatal care, many preventable problems would be missed that teaching hospitals couldn't impact. An important study was done in New York where the adequacy of prenatal care was studied. Adequacy was defined as prenatal care in the first trimester and having 10 visits. I wrote up a computer program with the data division of the Mass Department of Public Health using the New York definition of adequate prenatal care. We ran the program for 5 years of birth certificates for the late 60s for every city and town in Massachusetts and for 15 Boston neighborhoods. We found that the adequacy of prenatal care in some of the rich suburbs like Newton, Brookline, was 90%. The city of Boston was 40%, except for some of the few Boston neighborhoods with neighborhood health centers had over 5 years gone from 40% to 70%. This is all that Assistant Commissioner Lewis Pollock needed. He took the data to the Boston City Council and showed them the impact that neighborhood health centers could have in getting pregnant women in early for prenatal care, when many of their potential problems could be prevented. The City Council voted to begin financing and supporting the development of neighborhood health centers. Blue Cross quickly began to reimburse health centers, and teaching hospitals gave admitting privileges to health center doctors. Assistant Commissioner Pollock was thrilled. Health centers quickly spread throughout Massachusetts. In the late 70s, 80% of the community health centers in the United States in urban and rural areas were in Massachusetts. The federal government began reporting on the development of community health centers. The federal government supported this development. Community health centers in Massachusetts now support the diversity of the state's languages, cultures, LGBTQ populations. Much of this work has helped Massachusetts have one of the lowest infant mortality rates and maternal mortality rates in the United States, as well as the lowest percentages of uninsured people, subjects that will be covered in future lectures.